Okay, this is the Green Chilies Journal Club. My article was when doctors die, and it was basically talking about how like they see patients go through like extreme circumstances and like will do anything to like stay alive, and how doctors end up choosing not to. And so they're like doctors see it all the time, like the actual result of CPR and like how many people don't even make it, and like the ribs being broken, and like just you just end up getting intubated. And so he told this story about like this doctor that found out he had cancer, and he just quit his practice. He just shut it down, and he like lived for 6 months after or something like that. And he like didn't go through any extreme like treatments or anything like that, and he like just enjoyed his life, and then he died peacefully. And they were just saying how you see more and more doctors like not using like any extreme measures, and like when they are sick they just let themselves die. And so it just kind of shows like when is too much medical care like too much, and when does it go too far, and like when are we just prolonging someone's terrible life. So that's what there's about.
It's kind of telling that doctors like push to like help save people's lives with all these extraordinary measures, and then they don't want them on themselves because they've seen how how it can play out and what the outcomes of them are. So kind of a weird.
I also always think like everyone's like, I'm gonna be the one in the million, you know, like I'm gonna be the person that survives this, and then they see the other other 999,000 people that don't make it, and they're like, I don't want to.
Yeah. Well, like doctors make the worst patients, and that's why, because they see so much and are like,
and they know too much. Mm-hmm. Yeah, they know way too much, and they know what can happen and know how horrible it can be, so they just don't even do it. Like,
it's just like nurses. I think they say nurses also make the worst patients, but yeah, because you know a lot, you know what your body goes through when you're trying to survive, I guess. I don't know.
You know, like what kind of care you give, and like if you're not getting as good of care as you would give to someone, then you're like, well, this is crap.
Yeah, that's true.
I think it was super interesting. And not how to do an hour or anything like that. But the more you're in healthcare, it's the more you like kind of stuff and don't want all of that stuff happening.
Yeah, but it's also really interesting. You know, they wouldn't choose all the methods, but yet the time expressing their own opinions to patients that are facing the same thing as well.
Yeah, it's definitely interesting. Popcorn, Kenzie.
I knew you were gonna choose me.
I was just looking at you.
I did family presence during resuscitation, which I was really interested about this because we've talked about it so much in school, and just like how that's become a new standard is that family is there to see resuscitation, and there's evidence to back it, which is awesome, because this article really talked about how there is like so many benefits to having family in the room, but still healthcare providers are like, they're in the way. There's too much stress having them there. There's all these psychological, like, I can't even think of the word right now, problems that come from having them in the room, but that's not proven. It's more their own personal beliefs in that. And so this article talked about how nurses really push for having family in the room during resuscitation, and they looked at a bunch of different perspectives of family and stuff, and that most of them wanted the opportunity to have the option at least to go in and watch a resuscitation. And so really it comes down to healthcare providers and their opinions in that. And so it like looked at a ton of different hospital systems and areas and noticed that there was no consistency in a guideline or plan in that. And so the summary said it causes an inequity in care because it's unethical to offer the option of family presence during resuscitation to some individuals and not others. And so just like our role as nurses to push for that, and how there is evidence backing that having family in the room is really important and good, just to see the extent of what happens during CPR, and knowing that truly like the code team did the best they could, and you can see that firsthand. So it was interesting that the biggest pushback was from healthcare providers, but that's just what they talked about.
I had a experience literally like that in clinical when I was in the ER for my med surge our first year. This lady like was totally like coded, and they were doing CPR on her, and they called the family and they were like, do you want us to keep going? And the family, of course, is not there, and was just like, yes, do everything you can, like keep going. And then we waited, and we literally just kept coding her. We coded her like the max. We gave her the max epi dose. Like we literally gave her everything we could do. And she was gone. Like you could just honestly feel the energy. Like she was gone. Like this was not. And then the family got there, and they were like, stop, stop, stop. We don't want you to like stop touching her. Like they just did not want when they saw what she was like. So I think it's so important to like offer that choice to the family and be like, hey, this is what's going to happen. And also if the family is in there, I think it's so important to have a nurse with the family the entire time, not involved in the code, but is being like, okay, this is what's happening. This is what they're doing. We're not trying to hurt them, but this is what they have to do. Their ribs are probably going to be broken. Their sternum's probably going to be broken. Like now they're going to bag them, like things like that. So I think, but having that option of them being in there, I think is really important.
I also think that it might change what the family wants for the person. Like if they're not in the room and they just want everything done, keep them alive. But like you said, if they're in the room and they see what's happening to their loved one, they might not want it after that. Like it's like pretty harsh in there.
It's really scary. Yeah.
I agree with Chelsea.
Sal agrees with Chelsea.
Well, I just think it's interesting that healthcare providers are he disagrees. That healthcare providers are the ones that are having the pushback because it's too much stress, but that's because residents and like med students, you know, like who are just out of med school are the ones writing the codes, not the really experienced staff. Sorry, Sal, go ahead. I was just.
Oh, sorry. My dog was about to start barking. I was like, oh, I need to quiet her down. But anyways, I do agree with Chelsea. I think it's so important to have a nurse there for the family. I think that's an excellent idea to be able to kind of help them and walk them through that and give them support.
Yeah, I think, I mean, if I was like the family, I just would be so scared though. Like just thinking about, I guess, because I know, I feel like, so I'm like, oh my gosh, I wouldn't even want to watch to begin with. But I mean, I think it is important so that other people also know, so that, you know, they don't have to, you don't go forever trying to resuscitate someone, you know, because I feel like it is very hard on someone's body.
Mm-hmm.
I think it's all just like also a lot of pressure. Like I feel like that's what healthcare professionals feel. Like, you know, like the whole argument of like police officers with cameras or without cameras. It's like that much pressure of like, I think that's why people are like, it's a stressful situation, and like just having someone like watch you, and just with like, I think that's what I think of as like when I feel like, oh gosh, like I'm like, they're gonna, if something goes wrong, they're gonna sue, you know, like stuff like that. That's like, it's like the fear of that. Yeah. But I think it's the best for the families to be in there.
Mm-hmm.
Popcorn Sal.
So my I read is on culturally diverse communities, and basically what it's talking about is being culturally competent. I think that every culture views end of life support in different ways. We need to be able to respect them and understand that for some, talking about death is, you know, taboo for their culture, and it almost hastens, like it they feel like it brings bad spirits into their life, and so they don't want to talk about that. And so being aware of that and being sensitive to that as well, and knowing that every culture is a little bit different. As far as like for the Latino community, it talks about how, you know, they don't like palliative care. They don't they don't believe in life support. And, for example, they're talking about how hospice care, it's made up about 83% whites and only 3% Latinos and 8% African American. And so they talk about really trying to bridge that gap by using mental health resources to kind of help them cope through that, but also providing resources in their own language for them to understand as well.
That is so hard for me because I want to be respectful to people and the culture, but I just don't know enough. So I don't know. No, if I went and sat in a class on it, I still probably wouldn't remember. And you have to know what culture they are. I just feel like having open communication between you and your patient is really important.
Well, and I think there's just the cultural competency is so important, and we're not going to know all these cultures anyway, so there's nothing wrong with asking and starting that conversation. But I do think in our Western culture, we have a way of doing things, and that not everyone has to follow this direct step by step how most white people do it. And so I don't know, I think that's a really cool opportunity with a patient to be hey, I don't know if you have any cultural considerations, but what is your view in, especially end of life, I think is really hard. But I don't know, there's nothing wrong with asking, is what I think.
Totally agree.
Yeah, I think even I'm Hispanic, and I feel sometimes I still don't even know everything that there is to it. I guess I know what my parents think about end of life and stuff, but even then I'm we can think different things, and there are other cultures and stuff. So I don't know. Yeah, I think just asking is the best way to be culturally competent.
Yeah, I think it's always being ready to continue to learn, and even just being able to ask every time, because it might not even be the same. The things you learn about a Hispanic culture, they might not hold that. So always just asking, and asking in the best ways.
Yeah. And also another thing, I love the saying, be comfortable with being uncomfortable. If it makes you uncomfortable, that's okay. It's not comfortable to ask, what do you like to do when people in your culture die? That's not a comfortable question to ask, but it's just becoming comfortable with that uncomfortability and being hey, this is an important question, and I know it's hard to talk about, but I really want to know how you view this and what you think. So
as a nurse, I feel we just have to throw comfort out the window, because you're just going to run into everything. You're not going to know what to say or do, but you just got to roll with the punches.
And I think the culture diversity aspect of it is another layer, because I think this is already very complex, and it's a very tough topic just to even talk about. How do you connect? How do you talk about it? And then you add another layer of hey, I can't even speak the language that you speak, or, it's broken, and how do I fully understand? And I think that's why it's so important, like you guys were saying, is just being aware that it's going to be uncomfortable, but just working through it. Popcorn Chelsea.
Okay, so my article it's called The Symptoms of Protracted Dying. So this was a New York Times article, which I thought was really interesting that was in a huge newspaper, but it basically it's more like a story about this woman named Geraldine. She was 56 and she had a heart attack, and her husband performed CPR at their house, and then they called 911 obviously, but she had so much she just didn't get any oxygen to her brain for so long that she started just having seizures just all the time. So basically she was not herself. And it talked about just kind of they kept her alive, and because she was 56, and they didn't really talk about their end of life care and what they wanted. And so her family, there's a lot of quotes, her family would say, oh, if she was 70 or 80, maybe we'd let her go, but she's only 56. She'd want us to fight for her more, and things like that. And so And then it kind of goes through of what happens to someone when they're on life support. You know, they're intubated, they get a feeding tube, they get bed sores, they're immobile, they get all these complications, they get infections, and lo and behold, all these things happen to her, and they kept her alive for so long. And I think, gosh, how long did they keep her alive? I think 60 days after her heart attack. She could leave the ICU, but then she still wasn't responsive. She was in a vegetative state. And they just talked about the long-term aspect of keeping someone alive on life support and how it's really hard on the family. And then I think one of the interesting things is that was managing her care asked if another patient's family could come and like see her and see what it's like to have someone on months of life support, and the family allowed them to do that. And then the family of the other patient ended up put their loved one on hospice care. So after even just seeing Geraldine and what she was like after months on life support, they decided to just let her die peacefully, their other family member. So it was a really interesting article. It was really sad because she sounded like such a vibrant person, and her family described her as that, but it's like, and they described her as a fighter, but it's like, even though she might be a fighter, like, this is so hard on someone's body. And I think after the funeral and after she died, they talked about how they just didn't know what they were in for. And I think just educating people on what this is really like is so important.
Well, I think people have this like idea that their life is just going to go back to normal, but understanding and like teaching what is quality of life going to look like, especially after all of those measures being taken.
And I think there's like this misconception that like when they're brain dead, they can come back, which they've like said in TV shows and movies, and they've like proven that actually doesn't happen. It like is something wrong, like something happened where like they didn't read the test right, but it usually that like never happens, is people come back to life after being brain dead. And so I think a lot of people have this hope like it happened to someone, but and I also just think that it'd be hard to be a nurse and that's like taking care of the same person and like knowing that like they are never going to come back, but still like taking care of them because of the family, you know, like for the family.
Yeah. Another interesting part of this was it talked about how in every other aspect of medicine, doctors are like, we're going to make all these recommendations and we tell you about the pros and cons. But when it comes to death, we don't really talk about the cons of keeping someone alive. We just talk about, okay, this is what's going to happen if we do keep them alive. Instead of what they truly want to recommend, they just say, this is what's going to happen if we keep them alive, instead of being like, hey, I recommend you don't. Like, this is what it's going to be like. So I think that, and it even talked about like bed sores and stuff, how it was just found. And it even said like, thanks to aggressive nursing care, her bed sore was managed at an early stage. But it's like so true, because it's like, we just want to make these people as comfortable as possible, and we're aggressive about it. You know, we want to like make sure they're okay, but it's like that stuff is kind of inevitable. Someone who's caught in bed like is gonna get a bed sore, is gonna get complications like that. It's just,
and I was gonna touch on that too as well. You know, it's like these physicians, they have so much training on how to keep people alive, but yet it talks about how they lack education on how to have those difficult conversations when it comes to that point. And I think that we as nurses, that's where we can kind of bridge that gap, is connecting with the family and kind of helping them, connect them with resources to get them that information that they need as well.
It's hard to tell someone though that, oh, this person was supposed to have 30 more years of life, and now it's like over. So it like, when my grandpa was like in his hospice care, they're like talking about quality over quantity. So she's not going to have any quality of life, but she could live a long time on like measures. But it comes down to like, would you rather have someone be comfortable and like have a good quality of life, or just like live forever? Which is like the decide between times. Unless
Yeah. This just reminds me of when we were doing our children's rotation, when we had that like skit thing we did, where it was like it was a kid, he got into an accident, and they were trying to decide if they wanted to like keep him on, life support, whatever. And I don't know, I just remember like we were both split on each side, and we were just talking about like pros and cons. But I mean, it's just like hard in general, because it's like, especially a kid, like they're so young, like they have so much, like so many years to live, but then you think, well, are they gonna need someone to care for them every day? So I don't know, I mean, yeah, it's just hard.
This is where like medicine is hard, like with my article and that, like what is too much? Like even if we can do it, what is just like have we like even gone too far where people think like we should be able to keep everyone alive, and like no one knows like all the repercussions of those decisions.
Okay. Popcorn Jenny.
Okay, hopefully you can't hear my dog barking. Okay, so mine is variability of brain death policies in the U.S. So this kind of goes well after Chelsea's. But basically, this article was kind of looking at all the policies throughout the U.S. on how they determine patients to be brain dead. And it was just crazy because like everybody does it differently. And they looked at 508 policies throughout the U.S. and they looked at specific things. One of the things was who is qualified to perform the determination of someone being brain dead. And basically, I mean, there's just a lot of people that can be in charge of this. But it said that 43%, it was just any like attending could determine brain dead. But then the 33.1% of those require specific like expertise in neurology or neurosurgery, which was kind of crazy because I think, you'd really want to know about the brain and know that, someone is brain dead. And then sometimes some required like 2 different examiners to come and look at them. But yeah, it just was a lot of different people that could determine this. And some didn't even have to be like attendings. It was just a specialized person that like any licensed physician, primary attending physician, intensivist, a mid-level healthcare professional, which I don't know what that means, but I don't know. It doesn't seem someone who should be making that call. But then they also looked at like different tests they do, and basically everyone did different tests. But there is this, it's called the American Academy of Neurology, and they kind of have always put out these like policies and regulations on how to determine this. And in 2010, they kind of revised it and made it more specific, I guess. They had like step-by-step instructions and then like a detailed checklist. And so that's why they wanted to see if any of the hospitals were kind of using this. But I mean, through the results, it just showed that everybody still kind of did it in their own way. And at the bottom, it was kind of funny because I was like, it's probably just because they don't want to change. And at the bottom of the article, it said that basically people were like, there has to be a desire for change for everybody to change this, because if physicians and everybody are doing it already in a specific way or have their own regulations, they probably won't want to change it up. So yeah, I just thought it was kind of weird that there were so many different policies to determine if someone's dead. But
I would think that there'd be like a federal determinant, like not hospital, state by state, like one federal that was like all over all the hospitals and states saying that this is what it is. That's just crazy that in one state you could be declared brain dead by someone that doesn't know what they're doing, and you might not be or something like that if they're not specialized. That's scary.
Yeah. I also think it's just how like patient care is like very like hospital based. Like it would overall, if we had the same charting system for every single hospital, patient care would be better. But it's a business and not actually healthcare Like, that's not the root of it. And so, like, that's, I think the point is, like, everyone has their own thing because they have to be a little bit different because we can't have, like, all these universal standards because that would,
which would make
you know, like, but overall make it better.
Well, and how do you even like standardize medicine across the board, you know? Because then it has to be a worldwide thing too. But then even like comparing countries, healthcare is way different. And yeah. But it's because you're right, Casey, it is a business model. It's not.
But even if you see, like, the coronavirus vaccine, there's like 4 different companies like racing against each other instead of working together. Like, there's all these things of like, oh, someone's like, oh, we know how to declare someone brain dead and we'll like publish it, but like we want to do it faster instead of like share it, you know, like there's this thing. So I think that's very fitting. I was surprised, but not really, because I feel like healthcare is just different anywhere you go.
Yeah. And I think there's so many ethical dilemmas, you know, surrounding that. And I think that's why it's so important that we have those ethical committees in the hospitals, that when situations like this come up, they can kind of help walk patients, physicians, and nurses as well.
Mm-hmm.
Yeah.
All right, Bree,
Right.
you want to go next?
Yeah. Well, okay. So my article was exchanging a blanket for a code blue, and at first I was like really confused on what it might be. But it talks about how like crash carts are like all around the hospital, and like they're supposed to be used for the benefit of everyone. But some patients decide that they don't want to be like coded, because my article said fewer than 20% of people that were coded leave the hospital alive. Like, that's crazy. So my article talked about what we do for patients that decide to be DNRs and we know they're gonna die. So I know at the hospital I work at, we do have these already, and they're called comfort carts. So when a patient's like death is anticipated, mine at the hospital has like snacks and coffee and tea, like for family members to be more comfortable. But in this hospital, they have carts that have like handmade blankets, and then like plastic things you can like make handprints with your like dying loved one. They have all these like really like sentimental things to make the comfort of the family a priority as well as the comfort of the patient. So it talks about how nurses, when someone's like a DNR and on hospice cares, they might not give the best care for a patient, but there's so many things that we can do for the patient, even though medically we're not going to be doing anything for them. So they said that these like the information they put on the carts kind of in the objects used were for transitional objects for patients, family members to like take home and kind of find comfort in them. So I think it's really important not to just care for our patient in the comfort, but the family, because they're grieving and they're going through something awful. And the purpose of the carts, it says, to create meaningful in a sacred place around them and to help people grieve. So I love the idea of the blankets and like the plaster for people to bring things home, but even just something like we do with food is helpful as well for families.
Yeah, I didn't know. I don't know if UC Health has one of those, but I like didn't know those were a thing, and it like is very important to like also like care for the family, and it just like kind of reiterates the fact of like 20% of the people who are coded leave the hospital. So why do we expect doctors to want to be coded, or like why do we expect things like that? Like it kind of more or less makes sense, you know?
Yeah, I think that's really cool to like, I don't know, that death is such an uncomfortable thing for people to talk about, but this is like one of those things that helps normalize it and is like, well, how can we bring comfort and bring like care in the middle of a really hard situation? And I don't know if it's not necessarily that like, oh, food or homemade things fix it, but it helps I don't know, bring like recognition to a situation that's really hard.
I would agree. It's, sometimes we'll lack the words or we'll lack the ability to say the right thing at the right time. And I mean, there's so much suffering and pain in this situation, but sometimes it's simple gestures, I think that that's really important. Like she said, a blanket, different things that can just let them know, hey, we're here for you. And maybe that's the bridge. Maybe that helps them to open the lines of communication so, we can get that going.
Yeah, I agree. Or Chelsea?
I don't know. But yeah, I also think it's just nice. Like if I was the family member, I would definitely feel just like loved or just like cared for as well, which is, it's nice because you don't want to spend your, the last couple of days with your loved one in a hospital and, like it's not very homey. So like if you can make it a little homier, I think that'd be a lot better.
The article said like it's also meant to like make them not think about all like the monitors and the tubes and everything that's happening. It focuses them in on like something that can make it feel like home. So
Kelsey said it shut down.
okay, well we're done anyways.
Because I thought Bree's computer shut off.
No, that's okay. Go Green Chilies.